again. Welcome to our event, a call to action supporting healthcare in Northwest Syria in light of the COVID-19 pandemic, hosted by the American Relief Coalition for Syria, Syrian American Medical Society, and Syria Relief and Development. My name is Hazem Rihawi, and I'm the Senior Programs Manager with the American Relief Coalition for Syria based in Washington, D.C. Thank you all for joining us for this virtual event on the side of the Supporting the Future of Syria and the Region, Brussels IV Conference. First of all, we would like to thank the European Union, the Syria Desk in the European External Action Service, and the organizers of the Brussels Conference for giving us the opportunity to discuss the current status of health services and infrastructure in Northwest Syria, and to emphasize the need for the international community to increase its support to healthcare in Northwest Syria in light of the COVID-19 pandemic. First of all, we would like to notify you that this webinar is recorded and the recording will be available to you after the event. Please submit your questions using the Q&A feature that is located in the bottom of your screen, as the chat functionality is disabled for attendees. We hope that you will benefit from the presence of 4 brilliant Syrian experts in our panel who are working day in, day out in health programs in Northwest Syria and who have given us the time to participate in this webinar. And now we'll begin. So with the conflict in Syria in its 9th year, the humanitarian situation could not be more dire. As per the 2020 Humanitarian Needs Overview for Syria, 12 million people are in dire need of humanitarian health assistance, including 2.8 million people, nearly 65% of the population in Northwest Syria. Most of the civilians there are among the most vulnerable in all of the world. Children under 5 years old, elderly above the age of 65, and people living with disabilities who have been displaced multiple times in the past 2 years alone and are living in camps and overburdened areas. But after 9 years of conflict, compounded with access constraints, insufficient human resources, and systematic targeting of health facilities, in which 68% of attacks on healthcare confirmed between 2016 and 2019 were recorded in Northwest Syria alone. The healthcare system in Northwest Syria has been severely weakened to an unprecedented level and lacks the required capacity in terms of infrastructure, equipment, supplies, and the human resources to provide the much needed health services to the local population, let alone respond to new health crises such as the COVID-19 pandemic. With such a background, I would like to introduce our first panelist, Dr. Bachir Tajaldin. Dr. Bachir is a medical doctor specialized in internal medicine. He has been working in the Syrian humanitarian crisis from the beginning, first as a field doctor, and then he participated in the establishment of the Early Warning Alert and Response Network in Northwest Syria, where he was effectively leading the response to the polio outbreak in Syria. He is currently the Senior Program Manager at the Syrian American Medical Society office in Turkey. Thank you for joining us, Dr. Bachir. My question to you to start this panel, from your experience working in the health response in Syria, how has the health system of Northwest Syria evolved, positively and negatively, over the past 9 years of conflict?
Thank you, Dr. Hazem, for the introduction, and thank you all for participating in this discussion. First of all, as all of us know, that the Syrian crisis is a complex emergency. It's not just a displacement or environmental or natural disaster, but it has many of all topics of the disaster. So it's a complex disaster. From my experience in the Syrian humanitarian context since the beginning, actually the Syrian crisis have been gone into several stages. According to the access we have at the beginning, we have access to wide areas in northern Syria, starting from Latakia Governorate in the north to the Iraqi borders in the east. This area contained about more than 10 million population. Now we are working different segments of the area according to the accessibility. We have Northwest Syria, we have Northeast Syria with different access, with different working environment and different nature and different type of infrastructure. Actually, regarding the infrastructure, if we divided the infrastructure of the health system in northern Syria, either northeast or northwest, we have to speak about the infrastructure regarding the buildings and the infrastructure of other components of the health system according to the 6 pillars of the health system. If we are talking about the building or the facilities as a building, it's clear that we are working in places or spaces that are not designed initially as health facilities. Of course, if we review the reports, for example, the HIRAMs, we will find that we in Northwest Syria, we have about 54 hospitals. But all those hospitals have a capacity of inpatient beds. It's about 1,600. So they are small facilities. This is the needs for the situation on the ground. When you or when we and mainly the staff in the field are facing on daily basis targeting on the health facilities, so it's a dire need to segment those health services into different geographical areas to mitigate the risk. And on the other hand, there is a limitation, for example, in the mandate of many of the donors as and it's justified as they are dealing with the humanitarian and emergency situation. So the construction and the major maintenance of the building are almost prohibited by many donors. Only we can do some minor maintenance or minor rehabilitation to the facilities to meet the emergency needs. But also, on the other hand, if we are talking about the risk factor on the health system itself, we can see that during the last few years, we are dealing with population overcrowded in a small geographical area. Although the geographical area is shrinking, but we are still dealing with the large number of population who needs the health services. Unfortunately, all the risk factors that affecting the health service and are increasing during the progression of the health of the crisis in Syria. So, for example, recently we have this deterioration in the Syrian pound that affect the economical situation. So also this can affect the population with the decreasing the nutrient intake, which is main risk factor. We have the overcrowded population in the camps. We have the inadequate shelter during the last year, more than 1 million population. Out of the 4.3 million residents in Northwest Syria have been displaced again. The insufficient of the vaccination coverage. Also, this is the vaccination and the routine immunization is one of the biggest positive impact during the crisis. Thankfully, with the help of everyone, actually, the staff in the field, the local health directorates, the joint efforts from the NGOs and the health partners within the health sector. Thankfully, we could reactivate the immunization system, but although this is a subject of interruption due to the displacement targeting the health facilities. high exposure to disease factor, poor water sanitation and hygiene. All of those are factors. And most recently, the lack of treatment due to again, the poor economic situation in the field, the lockdown of many of the pharmaceutical industries that will add additional layer on us as a health sector partners to meet those needs. So in general, during the last 9 years, just to summarize, we have the same humanitarian crisis with peaks of acute deterioration of the crisis, different types of deterioration, displacement, natural disasters, the escalation in the military operations, while we have increasing in the risk factor that affect the health sector. In addition to that, we are still working on emergency situation that will meet some of the basic needs of the population, but there is a lot of health needs for the population residing in Northwest Syria or Northeast Syria need to be met while we are responding to this disaster. Thank you.
Thank you so much, Dr. Bachir. It's really great to hear about all of this and the efforts being done by Syrian NGOs and the staff. Before going to Dr. Mohammad, I would like to remind you all to put your questions in the Q&A, and we will aim to reply to as many questions as possible. We'll move now to our second guest, Dr. Mohammad Abrash. He's calling us from Idlib. Thank you so much for joining us. Dr. Mohammad is a general surgeon with the Syrian American Medical Society in Idlib city. He has 30 years of vast surgical experience. Dr. Mohammad was working inside Syria when the conflict started, and he saved many lives suffering from war injuries. In addition to his work as a surgeon, Dr. Mohammad is currently the secretary of Idlib Doctors Syndicate, and he is a prominent advocate who participated in many venues and conferences about the medical situation inside Syria. Thank you so much, Dr. Mohammad, for joining us. My question to you, Dr. Mohammad, is what is the current situation of the human resources working in health sector in Northwest of Syria? We heard from Dr. Bachir about the infrastructure, but as we know, human resources are very important. And how NGOs are trying to support the rehabilitation of the human resources in the health sector after 9 years of conflict. The microphone is for you, Dr. Mohammad. You need to unmute.
Thank you very much, Dr. Hazim, for this introduction, and I would like to welcoming you for Idlib Central Hospital to visit and see what we are suffering there. Actually, I'm working in field hospitals since 9 years, and we build the hospitals day by day by the assistance of our NGOs, especially SAMS. So I would like to thank SAMS for they improve our health system gradually, and but also we have to talk about our suffering regarding the human resources. In the beginning, we are only care about the life saving with the patient. So the number of the human resources was limited, and it's not so have many doctors and many staffs, and so because we are only giving the life-saving or aids to the injured people by the airstrikes or bombings, then we are shifting the people to Turkey to take more the care, health care. But now I can say about the health care in Idlib area or in north of Syria, it is unhealthy because we need more specialized people. We need more doctors in different specialties. Now all the people accumulate in this small area, and the number is more than 4 million. We have children, we have females, we have deliveries, we need ICUs, we need more advanced treatment like for the cancers, like we need radiotherapy, we need investigation laboratories like tumor markers or others, we need investigation like CT scan, MRI. All these things is not available, and the number of the specialists not also available. So to improve this, you need to improve the human resources. You have to start from the doctors, nurses, midwives, even for the any assistant in the hospital, like workers also. So we have to build a new system. We have to graduate new doctors, because the number of the doctor is coming less and less. And we lost many of our colleagues during these 9 years, and we lost many of our staff in that at pumps continuously, especially since 2 years till now. They are targeting, and we lost more than 66 centers run by SAMS. And all of you know about these things. So we have to start to build a new university. We have to have schools, for medical schools, to train the people. Now we are depending sometimes on trainers only. They don't have certificates to work as a health worker. So we need the support, the world, to build a new faculty, medical faculty, with different specialty. We need pediatricians, we need OB-GYN, we need radiologists, we need all the specialties in the medicine. We need it in this area. For example, just 1 hour back, one patient sent to me a letter that his child, he has a snake bite, and we don't have antidote. It's not available. Antidote is not available in our area. So the medication to be available. We need pharmacy. We need pharmacists, because you see, most of the pharmacists not having any certificate, opening one store, and they're bringing illegally the medication and selling the medication to the people. And we have many of side effects of this. They are changing the medication what we are writing for them. Actually, also we have a shortage of services in the hospital itself. For example, I will give you example for ARCS. This is very important machine, and it need to be available in our area, and it will save the operation for the patient. And it is there is a machine, but it is all of out of work, and we cannot. And we don't have a specialized doctor to work on this machine, ARCS machine. For tumors, SAMS, we have to thank SAMS that they have one center in our hospital for tumors, and they are treating only 3 kinds of tumor: Hodgkin lymphoma, and breast cancer, and colon cancer. But also, after we are treating those patients, we don't have radiotherapy to continue this medication for those people. So really, it's so important to rebuild the hospital by rebuilding the faculty of medicine. And SAMS, they started the program of SPOMS, and the SPOMS, they started to improve the doctors who was resident, who resigned from their from the college in the area of regime, and to us, they cannot continue there. So we have to cope with them, and we have to improve them and give them residency to graduate as doctor. So we have a system, we need a system to build. Also regarding children and regarding the ICUs, really especially for the neonate ICU, and for the ICU, especially now in COVID-19. And fortunately, we don't have any case till now. But if it will spread, and actually it started in the regime area, and they start to have cases, if it to us, really we will be shut down. And also, they started one hospital in Idlib area to treat those COVID-19 positive patients, but need training for those people. We need the help of the training. Actually, we don't have a specialized internist who is dealing properly with those cases. And WHO, they the Idlib area by some PCR, and it is few number of tests. It will not be enough to continue if there is any future. So really, it's so important to continue the education. We need to build continual medical education system. We don't have it because we don't have time. Actually, all the staff, I can tell you, most of the doctors, they have suffering, especially who's in Turkey and families in actually living inside this area, and there is a problem in the crossing the border. So this is a problem. If you need to have vacation for a few days, you cannot, because there is no replacement for you. So really, we are suffering too much. For me now, more than 3.5 months, I did not cross the border because it is blocked by the Turkey. My family is there. I cannot see my family since long time. So really, it is a suffering. We need to have more doctors. We need to have more nurses, midwives, more pharmacists, more laboratories. So really, it's so important to rebuild the healthcare system.
Thank you so much, Dr. Mohammad. It was really very insightful remarks. And just to explain to the attendees that the SPOMS that Dr. Mohammad talked about is the Syrian Board of Medical Specialties. It's an initiative to support residency, and it could be, and it is one of our best entities to train doctors, and we think it should be supported and helped by everyone. Thank you so much. And based on this, thank you, Dr. Mohammad. From this, I will go to Dr. Okba, and thank you, Dr. Mohammad, to talk about COVID-19. Based off all of these from before, I would like to introduce Dr. Mohammad, Dr. Okba Doghim, who is the Health Programs Manager at Syria Relief and Development based in Turkey, and he's traveling to Syria on a regular basis. Dr. Okba is a physician with a robust background in clinical services. He's a certified clinical management of rape and reproductive health services trainer, and serves as a supervisor for the World Health Organization's Mental Health Gap Action Program. In response to COVID-19 pandemic in northwest of Syria, he currently sits in the COVID-19 task force, in which SRD leads the infection prevention and control pillar, the IPC. Thank you, Dr. Okba, for joining us today. And based on the discussion and the remarks from Dr. Mohammad, as a member of COVID-19 task force, what has been already done for the response of a possible COVID-19 epidemic inside Syria? And what are the current gaps and shortages in the response plan?
Yes, thank you, Dr. Hazem, for the introduction, and good morning all. As mentioned, I'm Dr. Okba Doghim, medical doctor. I'm a urologist acting as health program manager for SRD. Actually, based on the current epidemiological situation in the region and neighboring countries, WHO considered the overall risk for Syria to be very high, and considering the disrupted and fragile health system, the risk of the spread of the disease is high in North and West Syria. Actually, the risk of imported COVID-19 in Northwest Syria and further local transmission in the community seems high owing to the following reason. There's a large density of population in Northwest Syria, especially in IDP camps. More than 1 million people have displaced within the last 6 months, and thousands are still living under trees without basic services. More population movement from Turkey and regime areas in summer and after mitigation their precaution measures. Also the difficult living situation conditions and ongoing armed clashes in Northwest Syria increase the vulnerability among the population to any infectious disease. As a response to this situation, COVID-19 task force has been established in March 2020. Preparedness and response plan for COVID-19 in Northwest Syria with the support of health cluster partners, technical working group has been created with 8 key pillars. Here I will focus on what mainly done and the main gaps. Let's go for pillar 3, the surveillance and rapid response team and case investigation. ICU has already been conducting COVID-19 surveillance activities in Northwest Syria. The standard case definition, case investigation, and follow-up for activities for active surveillance. There are also bulletins being issued on weekly basis focusing on COVID-19. So far, only one PCR testing lab is available in Idlib, which is the only source of testing the samples collected from suspected cases in the area. For pillar 4, point of entry, since it's essential to adopt the needed measures at the cross borders, cross lines, point of entries at all, in terms of screening travelers and moving in and out of Northwest Syria. And you know how it's important to control this because it's the essential prevention measure. Recognizing the suspected COVID-19 cases and refer them to the designed facility. SRD, in partner with the WHO, is implementing a project to strengthen the health system in response to COVID-19 pandemic. This project is covering the point of entry, 5 cross-border and 2 cross-lines points, with sitting triage teams at these entry points, in addition to 25 different locations inside Northwest Syria, will be covered by COVID-19 referral system. Through this project, training will be conducted targeting around 500 paramedics and drivers or unrelated protocol and IBC standard measures. The main challenge here that there's some new cross-border now partially open, so we need more teams, and also we need mobile teams to cover this new point of entry. Under laboratories, pillar 5, so far only one PCR testing lab is available in Idlib, which is run by ICU, and it's the only one, only resource of testing the samples collected from the suspected cases in the area. And there's a plan now to add 2 other PCR labs in the area, one in Jarablus and one in Afrin. Under case management, and it's really important, 2 community-based isolation centers and 3 hospital-based isolation centers has been designed as a referral unit to manage the confirmed COVID-19 cases, mild and moderate in CBIs, and severe and critical cases in the referral hospital or ICU hospital. Training have been conducted on specialized IBC and management protocols targeting the staff working on this facility. The main gap here is one of the only 28 intensive care unit, ICU unit beds with 22 ventilators are ready in isolation hospitals to receive the severe cases out of 90 planned. Also, only 2 community COVID-19 treatment center are operational out of 30 planned. So we need support to have our plan in place. Under infection prevention and control, SRD has been a task force member with an active participation in the most of pillars, especially this one, through developing the triage system protocol and conducting IBC and triage TOT for approximately 747 senior health staff working at 209 fixed health facility and 4 designed COVID-19 isolation centers through WHO and UNFPA funding. The last one, the pillar 8, operational supporting and logistics, the WHO supply chain unit has worked on needs assessment template to be distributed among health partners, and it's in process of delivering shipments of PPEs, personal protective equipment, and also the equipments for the hospital. UNFPA through SRD provided all her partner with PPE kits to cover their health facilities. Still, we have some challenges. I will summarize in a few minutes. Global shortage on IBC and PPE supplies continue to impact plans of providing health health workers and communities with infection prevention and control measures. Procurements at both local and international level is a major challenge, especially in procurement ventilators. With the current emergency and nature of pandemic, donors are requested to provide maximum flexibility to extend existing fund to allow for reprogramming where necessary. Economic situation is also an essential part of the bigger concept of prevention measures. The most recent economic collapse and change in currency means that some people are living on less than $1 per day. So it's very difficult to keep them isolated in their shelter. That's all. Over to you.
Thank you so much for the information, Dr. Okba. And it's really remarkable the work that has been done by Syrian NGOs and partners in preparedness for such situation. But I believe that, and even from your numbers, that we are still short of being able to respond for an epidemic of the size of COVID-19. And that's why we need to accelerate the funding and accelerate the support for these efforts that are already in place, but lack the funding to move and work quickly. We would like to remind our attendees to present their questions and in the Q&A section. So that we will be ready to respond to you after that. Our final panelist today is Ms. Amani Kanjo. Ms. Amani holds a bachelor's degree in bioengineering and a master's degree in molecular biology and genetics. She is currently the protection and GBV programs manager at the Syria Relief and Development in Gaziantep, Turkey. She co-leads the Youth and Adolescents Task Force, and she is a member of the Adolescents Reproductive Health Working Group in Northwest Syria. Ms. Amani has contributed also in developing the UNFPA Whole of Syria Adolescent Strategy and GBB Standard Operating Procedures for Syria in 2018-2019. A key focus of Amani's work is to integrate health and protection programming to enhance coordination in the response. As always, Ms. Amani, thank you so much for joining us. and it's really impressive the way that you have progressed. Definitely, I mean, we also know, Amani, that beyond physicians, nurses, midwives, social workers, and GBV case managers are such key actors in the health response. What kinds of challenges are faced for this workforce? And can you explain for us more about the challenges faced by female health workers in Northwest Syria? Please go ahead.
Thank you, Hazem, for the nice introduction. And continuing to what Dr. Mohammed has started to talk about human resources and their challenges, I wanted to add here more. Like, unfortunately, but worthy to say that many female health workers reported negative or possibly discriminatory experiences at workplace. One of their main concerns was maternity protection at workplace, as for example, pregnant and nursing workers, they consider that they don't have fair maternity leave. They don't have enough breaks for breastfeeding, pressure to return back to work while they are at leave because there is no replacement staff. As Dr. Mohammed has mentioned, the lack of human resources, qualified people, besides negative comments or complaints about inconvenient time of pregnancy by their line managers. And they also, that influences the recruitment and job offers at earlier stage. Secondly, like the contextually stereotyped and traditional gender roles in household itself in regards to house chores and child rearing, with the same overload of work comparing to male health workers as well in workplace. So the result that many female workers has difficulties in staying and working night shifts at works, so that all burden the work itself. Additionally, like, female workers reported that they are not considered equally valued like the male workers, and we rarely find managerial positions in hospitals and primary healthcare centers. So all mentioned before actually issued that the female workers had to sometimes to forced to leave their jobs, sometimes to influence their decision to stop breastfeeding. Either they are working at obstetric and gynecological clinic, which is really strange. And they influence their opportunities, their status, their job security, and eventually impact health, welfare, and their welfare. So as a solution, we can consider that granting pregnant and nursing workers some equality and flexibility at working hours and budgeting, and granting for replacement staff and duty of care, of course, and for sure creating discrimination and harassment-free atmosphere at workplaces. This is what we want most highlight at this point.
Thank you so much, Amani, and it's really important to understand all of this. And yeah, it is definitely an important thing to reach out to the female and understand their needs, especially our colleagues, the female health workers. We don't see any questions here till now, so please, if there is any questions, I'm really glad to answer them. But until we see such questions, I will go back to Dr. Bachir and have another question that when I was listening to you, and it was really important for us to understand more about the health infrastructure. What do you recommend supporting in the future efforts to rebuild the health infrastructure in Syria? I mean, we have seen, you have highlighted the needs and there has been lots of gaps, but the question that comes in our mind that we always being asked, what could be done inside Syria? What could be the next steps for us working inside Syria?
Okay, thank you, Hazim. And actually, if we are looking for the future or to rebuild the health system, we don't need to wait until the crisis to be end to start working. Actually, it's very important that we need to start from yesterday, even not from tomorrow. Looking at the overall picture in Northwest Syria, as part of Syria, we need to rebuild health system more than just service provision. Let's start focusing on the life-saving in addition to the life-sustaining health services. Actually, in this approach, we can also targeting the most vulnerable groups. For example, the people with chronic diseases are part of our response, including the NCD diseases, the hypertension, the diabetic mellitus, but yet we have a big gap in managing the cancer cases. Of course, there are many of the cases are referred to Turkey to receive treatment, but it's not the ideal solution, because the patient who is referred to Turkey or other area need to be accompanied with other family members. That will add additional layer of challenge. We don't, in Syria, if we support the treatment of the cancer cases or the oncology projects, we will need the cost of the health services, while in referring to other location, we need to provide health in addition to the food, shelter, livelihood, and many other services. We can touch this need as we are supporting one or almost the only oncology center in Northwest Syria, and with limited resources targeting some of the types of cancers, as Dr. Mohammed mentioned, and we are going hopefully to expand to other areas according to the resources. So it's just if we are building the system rather than service provision, so we are mitigating the need for other kinds of support, including the family support, livelihood, and food in other countries. Yet we have a big gap in the diagnostic tests. Now we are providing very essential diagnostic services that is in line with the essential services or the basic services. After 9 years, we are delaying so many of the non-emergency or non-life-threatening cases. This, of course, it's not life-threatening cases regarding health, but that affect the lifestyle and the productivity ability of those population. So 9 years, maybe some medical procedure which are not emergency, but it's cold cases. If we treat those cases, we can participate in improving the economic situation of the population or the resilience of the population on the ground. Very important. Now we are in a good example, and it's it's a critical example. Not for the NGOs, not for the donors, not for the healthcare workers in the field, but it's for the whole components of the health sector. So now we have the expected COVID to be in Northwest Syria. This outbreak already before the COVID, the numbers about the availability of the ICUs and the ventilators in Northwest Syria, there is about 100 ventilators for the population in Northwest Syria, which are 4.3 million. So we have at least a gap about 60% of the ventilators in Northwest Syria. With an outbreak like COVID or any other outbreak in the future like the COVID, how this health system or health structure will be able to manage the situation. So it's very important also, as Dr. Okba mentioned, filling the gap, activating or functionalizing of the PRP. It's very important and it's very urgent. Another issue we need to talk about is the bleeding of the healthcare personnel. So we have a lot of our colleagues have been killed during targeting the health facilities. Many of them are in detention, and a lot of healthcare workers fled out of the country and migrate to many of the countries. During the 9 years, we don't have any of the new generation of the healthcare workers. So maybe SAMS, other NGOs started thinking early in this gap, but yet the gap is very important. Currently, we have a shortage more than 50%, more than 65% of the healthcare worker availability, just for the minimum standard, not for the ideal situation. Okay, so we need a new blood in the in this field, the health, or this component, very important component of the health system, which is the human healthcare forces. So it's not just related to physicians or specialized physicians, but also it's related to the nurses, technicians, pharmacists, midwives. So it's really very important. We started some small initiative. It's we get support from some of donors, and also we can see the interest of the technical working groups as well. For example, UNFPA and Reproductive Health Technical Working Group supported us in the midwifery program, providing the technical supervision. But yet, after graduating, some midwives, and now they are working in the health facilities in Syria, but still there's no accreditation to be provided for those workers. Accreditation is the it's really critical. We're not for me, if I'm going to participate in an education program, why I'm losing some years of my life without accreditation, without future. So it's really important for all of us to see and discuss the current situation as it is, plan for providing certificate for those group of the population in Syria, and of course plan for the future, how to integrate them within the unified health system. Education itself, the general education is very important. Now we have the current experience where there's no or there is lack of education in Northwest Syria, where many of the students are obliged to go to the government-controlled areas. Within the COVID-19 outbreak, and when outbreak is confirmed in government areas, and those students are going back to Northwest Syria again within a few days or within a month. So they will be most likely will be carrying with them the virus to Northwest Syria. Okay. Finally, the last point I want to highlight is the governance. Working on empowering the governance, the health governance system in Northwest Syria will have a great impact, benefiting from one of the main lessons learned I personally participate in during the polio outbreak, when we were targeting about more than 1.5 million children to be reached by polio vaccines. It's door-to-door campaign. This campaign was not to be successful without the field management of the local health authorities, including the local health directorates and the local health councils at that times. And now the API itself is managed by this network of the local health authorities, managed by the health directorates in the field, and with the technical support from WHO, UNICEF, and the other and the participation of other partners. So health governance is on the top of the needs to build the health structure, and under the umbrella of the health governance, we need to focus on the 5 other components of the health system. First of all, medical education and the human resources, providing more and additional human resources to the sector, in addition to looking at the population, not from the eye of the health services, but as an overall approach, including the healthcare service. Thank you.
Thank you so much, Dr. Bachir, for answering this question. I mean, it's really important to look at all of these things and to have short-term plans and long-term plans. And we need to activate the long-term plans, especially after we've seen how important is the health system structure in how strong it should be to be able to take on the shocks like the COVID-19 pandemic that we have seen. We have received questions, and I would like to ask the first question to Dr. Okba. Could you please give us an assessment of why there are still no confirmed cases in Northwest of Syria till now? I mean, we have seen that it's a little bit, we know that we have been participating in many discussions about all this, but is there any additional information that you can add about this?
Yes, maybe it's complicated, but you know, it's like Northwest Syria, it's like semi-besieged area, you know. The movement is limited between the area, even inside Northwest Syria, like between Idlib and Afrin, between Afrin and northern Aleppo, and Tel Abyad area. There's limited access between this area, and there's no access to regime area now. Like like stop the cross border between Northwest Syria and regime area, and you know, only few people can cross the border to Turkey now. So you know, these cases must be like cross the border to be inside Northwest Syria. And as Dr. Mohammad Abrash mentioned, even the doctors now denied from crossing the border to Turkey or the opposite side. And also, the last point I want to add, there's no confirmed cases are likely due to the current limited surveillance system. You know, only few hundred of this was done till now inside the only one BCR or lab inside Idlib. So, you know, you have to test more to get ensured that there's any cases or not.
Thank you, Dr. Okba, and I totally agree with you. We have seen such things, and we actually even, we know that WHO has said that Mostly it is because of the weakened and fragile health system that is not able to probably detect the cases. But still, we know that preparation are ready, and it needs to be increased and funded for the longer term. I'll send question for you, Amani. I mean, donors have been asking how they can improve gender equality in the health workforce, especially in our areas. You are on mute, Amani.
We can say that the donors can reinforce or assuring that the local NGOs and grassroots NGOs can has a clear gender mainstreaming policies or strategies, showing them that there is a real implementation of what there should be a capacity building, duty of care policy as well. All of that helping in for the NGOs to implement it in a right way, allocating maybe some a good funding for integrated health and GBV projects, ensuring that all capacity building and as I mentioned, like duty of care for female workers is in place.
Excellent, excellent. Thank you so much. Dr. Mohammad, I want a question about, in general, about the health governance that has been mentioned by Dr. Bachir Tajaldin. So Northwest of Syria has been characterized till now by NGOs doing health service provision rather than the state. How has this been working so far? What is the importance of supporting local health governance?
Thank you for this question. Actually, it's important and so important for this to continue in the same manner. But actually, it's not enough. We have to start education actually from the primary school, secondary school. Then we have to have the medical university from Turkey, for example, to accredit the certificate which we are giving for them. Actually, we are helping our residents. We have some residents, only few residents. We are helping them. We are teaching them only doing operations or something. We are not teaching them the full education, the full system education. They have to run in system. And we don't have this system because we need to serve the patient. We don't have time to give lectures. We don't have to have, we don't have library for in the hospital. We don't have even one reference book in the hospital. So you need rebuild this system from the beginning, from zero. You have to build it, and you have to look for a few years, not only in 1 year. So we have to cope with other medical university for all the type of services, midwives and nurses and all kind of medical services. And we have to concentrate on the doctors, especially who's newly graduate and who leave the university in the regime area and have accreditation. They are preferring to go to Europe or to escape, actually cross the borders and illegally and go to continue their education in Europe, for example. And I saw many people, I know many of them, they are now in Europe. So we have the environment, a good environment in our area, and we have to have the facilities. If I will talk to them about laparoscopic surgery, I should have scope inside. The laparoscope which I'm working on in Idlib area, it is the age of 20 years now. It was used in National Idlib Federal Hospital, and we after free Idlib, we took it from the hospital and we are working on it. Actually, now it's out of work, actually. And since few months, we are not doing any laparoscopic surgery. So how the resident will be learn and he will give and how he will be improved. So really, it is a big manner. It needs a good, really economic status. It need more money. It has to have a good system to improve this and start as 0 point till the graduation of doctors.
Thank you so much, Dr. Mohammed, for your answer. I would refer to another answer for you, Dr. Okba. How effective are the referral systems currently in North Syria?
Yes, as SRD, we start working on the referral system from 2018 with the WHO support, technical and also funding. We start this in maybe with few facilities, and then we develop this referral system. Now we are including more than 100 facilities inside Idlib in this referral system. And also WHO established a central referral desk in Idlib, and now it's very effective to coordinate with all partners working on referral system on the ground, connecting all the facility with each other, and like we building, starting to build like network inside this area to know where you need to refer and which services in each facility are available. And you know, I think we have challenge here. It's it's still for the community how to reach this ambulance cars. You know, there's no cell phones or like line phones or network inside Syria in some areas. So some areas can reach this referral system by calling, and other cannot reach this referral system, and we are trying to solve this issue. Now, I think in Afrin area, the situation is better because, you know, the support of the Turkish directorates there. They support the referral system to strengthen this system to cover all the area and all health facilities there. And also they connect the referral system to the referral to Turkey, you know, through the cross border. Now we plan to start the referral system in northern Syria. Maybe it's like one gaps we face till now, because there's no referral system on place till now in North Aleppo. Sorry. So we have to start this referral system and connect those together. I think it will be very effective. Thank you.
Thanks a lot, Dr. Okba. And yeah, it is really, really important. And we are really proud of the work that has been done in the referral systems in North Syria. I would like to refer back to the question. And I would like to ask this to Dr. Bachir, because of lack of availability of a government in northwest of Syria, and that we don't have a central government that can support all of this and invest in health system strengthening, what could be the role of NGOs to contribute in building and strengthening the health system? I know that SAMS and SRD and other Syrian colleagues have been working on this, but what can be a better way? How can we ask donors and how they can be invested in all of this?
Yeah, thank you. It's a very important question, and actually I want to assure what Hazem mentioned, that unfortunately there's no government in the area we are working, and even there is a governance, let's say health governance system we are working in as a sector. So as an NGO working in this area, we are working and moving together as sector. Every NGO is filling part of the gap, but really the governance in this area in Northwest Syria are not supported in the right way. So strengthening and supporting a governance system, really it's important to coordinate the response in the field and providing efficacy and efficiency of our work and avoid any duplication. Of course, the coordination here from the cross-border between the all the partners, it's really very good and fascinating, but also we need the coordination with one governance system who is leading, for example, the referral networks and the ambulance system. Some of the important programs like the medical education, let's say, what's the clinical training of the medical education, what's the program? It should be managed by one entity. If we support or strengthen the governance system, by the end of the day, all NGOs will follow one standard regarding, for example, it's very basic issue. It's the salary scale of the healthcare workers. We are not finding ourselves just preparing our proposal to the different donors. Every organization are following a specific salary scale, which it's internally developed this system. While the governance system, it's a need for all of us to put the standards of those issues. Our role as an NGO is to support the health sector through the service provision or any other pillar we can participate according to the different areas of experience of and the mandates of different NGOs within the limits of the humanitarian principles and the regulations that we need to agree about as a sector. All partners of the sectors, including the UN agencies, donors, NGOs, and also in the participation with the staff in the field, which is very important. So this governance system can provide the baseline that we can build on, including the basic regulations of every pillar of the health system, and also the logical portion between the life-saving and life-sustaining services, and distribution and mapping of the services in the best way. Thank you.
Thank you so much, Dr. Bachir. I want to ask Amani, we know that negative health outcomes do not happen in a vacuum. Can you tell us more about the integration approach that is taken now in Northwest of Syria to link health and protection?
Yes, sure. That could be also a good answer of the question. What is the structure of the project that they need to allocate and fund? Statistically, one of the gender-based violence subcluster incident reports showed that 47% of rape cases required immediate clinical management of rape, and 53% of the cases were disclosed directly to medical staff and then referred to GBV specialized services, whereas 47% of the cases disclosed to GBV service providers and then referred urgently to medical staff. We can highlight the importance of collaboration work between gender-based violence and health actors. So the health services are often the first and only point of contact of the gender-based violence survivors seeking assistance. So in order to facilitate the care, survivors need to have safe access to health facilities. That means safe transit from to facilities, also confidential entry points, for these services. And it's also critical that the health providers working in emergencies are equipped to offer non-discriminatory, non-judgmental, quality health services for survivors. So I wanted here to highlight that the importance of the relationship between case management, which we call it specialized PSS for GBV survivors, and also adequate health intervention, which is really life-saving in some critical rape cases, that which shows the confidentiality, privacy, and healthcare could save lives of many survivors from honor killing and the lives of mother and child. So as GBV specialists, we always wanted to increase the understanding of the rape symptoms, especially in instances where the families approach to health facilities to request virginity test and of their family, female family members, and understanding that virginity tests itself really it's a sexual violence for her again, re-victimize her, re-stigmatize the girl itself, which is already a survivor of a rape violence. So all of that together, we want to put minimum protection requirements in health system, in health facilities, which is private setting infrastructure, and which is not stigmatizing, of course, accessible inside health facilities, and training the health staff to ask and respond appropriately, non-judgmentally attitude, and train on clinical care for sexual assault as per standard minimum initial service package, the MISP, and confidential consolidated referral system between health, mental health, and GBV systems. And of course, clear SOPs and protocols, which is, we call it clinical management of rape protocol, to be trained of all the health staff.
Thank you, Awan. And as always, it's really important to look at all of these things, and it's really important to look at all aspects of the health response as well as the protection response. We'll have the last couple of questions that we would like to answer. And Dr. Bachir, I'm referring this question to you. How would you recommend setting up a pre-service training in order to guarantee that it could be recognized, accredited, considering the uncertain status of Northwest Syria and the volatile security situation? This question has come us, and there has been a long debate about how we will be able to give accreditation in all of this. Is there any prioritization in terms of where donors can invest in to be able to, first of all, increase the health workers, the number of health workers, and to make sure that the training quality is important? I'd like to ask this to Dr. Bachir, and then probably I would like to hear also from Dr. Mohammad Abrash.
Yes, actually, it's a very important question, and it's when we are talking about medical education, just for the medical education itself, there is a lot of standards and technical details behind that. To answer this question, please let me use two current examples. The first one related to the physicians or doctor, and the other regarding the midwives. For the medical doctors, we are not just picking up anyone and giving access to the medical specialty program, but it's done through an entity or which is SPOMS, the Syrian Board of Medical Specializations, which is a group of physicians, specialized physicians with academic background. They are some of them in Syria, some of them in Turkey, and some of them are around the world. For example, if I speak about the internal medicine specialization, there is a committee of internal medicine specialization. It's from specialized physicians in Syria and Turkey. They are supervised, and also a lot of members of these committees are from SAMS member, academic SAMS member working in universities in the US. So this committee is providing day-to-day supervision of those resident physicians working in the hospitals inside Syria, setting up a curriculum based on the studying years, including the general internal medicine and the subspecialties. So there is a specific curriculum, specific plan, and there is also specific selection criteria for those residents. So the resident could not work as a service provider. He has to attend a specific number of theoretical lectures, a specific number of cases in each specialty, and he or she cannot do his training in any of the facilities. There is a selection criteria for the training facilities. The minimum standard need to be met. So this is, sorry, but during the time limitation, it's just very few. For example, in the SPOMS, there is about more than 260 residents registered by SPOMS, and SPOMS are not absorbing all the residents, but they are absorbing the number of residents who can be contained in the accredited hospitals from SPOMS side. Okay. The other example is the midwifery training program. It's really a collective effort from a lot of partners. We started talking about the midwifery training program by the needs assessment implemented from the field, identifying the gap by the health sector components in the field, the cluster, NGOs, health directorates, and we started developing a strategy. This strategy, or the midwifery capacity building training strategy for Northern Syria, it has been drafted by partners under the health cluster and the technical working group. Then this, and in coordination with the international consultant. Then it was approved, and the next step was to implement this strategy. The implementation was based on a detailed program planned from the selection criteria, who can be enrolled in this training, the curriculum, the training materials, the supervision, the number of hours per each training material, and the duration of the study. So all those standards are in place, which are contextualized with the Syrian context. So the missing part is the accreditation. It needs to be done in coordination with some universities. And of course, another gap is the appetite of the donors to support such programs, because the number of programs supported regarding medical education are very limited. The final word regarding this, enrolling population into medical education or any other educational program, this is a mitigation measure for the whole population or the situation in Northwest Syria. Thank you.
Thank you, Dr. Bachir, a lot for this. Now while we are wrapping up this webinar, I would like to ask Dr. Mohammad about the same topic that Dr. Bachir has said about what would be, if you are, while you are inside the camp, what would be the two cadres and two specialties that you think should be in our future? And you can summarize at the same time about the human resources, Dr. Mohammad.
Thank you very much. As Dr. Bachir, he told, it's implemented by, but always between the internal medicine and the surgeries. Actually, internal medicine, they can teach each other by webinar, like example. Okay, they know everything, but he will not me. They know everything, but do nothing. For surgeries, especially in general surgery, neurosurgery, urology, orthopedics, you need to teach the trainers inside OR. We have a rule that you have to see one, assist one, and do one. And to do this, you need a lot of resources. You need to have a good OR with. You should have all the instrument inside the OR. You need to have a program, continuous program. He will not, the resident, he will not jump to do, for example, gastrectomy, and he did do appendicectomy. So this program, it needs a lot of time. You need a lot of resources, and you need a lot of human resources also. So you have to have something on the ground. We need to have surgeons, neurosurgeon, for example, or urologist, or also to be on the field. Actually, nowadays, if we have any problems, we are running to save the lives of the patient. We are not running to tell the resident how to operate this case. We have to save his life. So the system and the teaching program is different in the medicine program. We need, example, for the neurosurgery. Now there is many cases of tumors and need microscopic surgery. And there is only one doctor in the Northwest. He is working on this specialty. And he really is willing to teach all residents. But there is no microscopes in every hospital. So the chance for the resident to see one case, it is very, very few. So this system need to be rebuild again and rehabilitate again, and the SPOMS has to be supported more and more. And we need other doctors and who has experience to come with us and stay with us and teach. Really, we more support from them. So, and this, it need really accreditation from university. We need medical university to, if we graduate the doctor, he has to have certificate that he can work as a specialist. NGOs, they are looking for the certificates, and your certificate should be not, cheated, and you can write it anywhere and give it. So has to be a real certificate. So the problem is big problem and need to be think about it and rehabilitate again.
So much, Dr. Mohammad. Final words, Dr. Okba. I mean, I know that SRD has been investing a lot in all of this. What do you think, like, as a final thoughts about the specialized services that Dr. Mohammad has mentioned? What do you think, in addition, from the NGO perspective, and what can NGOs can do about all of this? In a few minutes, please.
Yes. Actually, after 9 years of crisis, we need to focus more on health care quality to improve our health system. Specialist services available is limited due many reasons. During the last 9 years, most of cases which need specialized centers were referred to Turkey, you know. Due to COVID-19, this access is now not available like before. Just 5 cases per day could move to Turkey, and other cases should wait on the list. I'm going just to give overview about some gaps. Specialized diagnostic equipment such as CT scans, MRI, mammography, advanced diagnosis labs, specialized unit for cancer management, also cardiac disease and burn, cardiology services as caster services, bypass process, endoscopic surgery, really in need, and psychiatric hospitals. You know, there's no hospital existing in North and West Syria, and supporting centers for children with autistic and mental health disorders. It's very important. Disabilities are a critical issue. We need to focus more on how we could help them with specialized psycho or physiotherapy and rehabilitation centers, etc., and also to integrate this service inside our health facility. I want to stand also with our colleagues when they assure the importance of health education. You know, it's very important to focus on this, and we just to this information that we established a midwifery and nursing school in Afrin by funding by UNFPA, and the certificate will issued by the Education Ministry of Turkish. So we have the chance. We must focus more on health education. We want to more have this as important issue to solve this problem.
Thank you so much, Dr. Okba. And any last things before we wrap up? I mean, we have already 1 minute to end, or we have already finished, but we will try to give you a small space.
Always sustainable funds is always welcomed in such emergencies. Like 1 year or 2 years is really overburdening and over pressure on the stability of the programs, on the projects. So we always asked for long sustainable funding that really helps to establish a strong health and integrated health systems.
Thank you so much, Amani. I would like to thank you all for all of your contribution. And just we want to end by insisting and asking all of the donors and all our colleagues here to support the health system inside Syria. Humanitarian assistance is still a priority inside Syria, and funding should be increased. I mean, there is an existing funding health funding gap, which is, I mean, the latest report, the latest bulletin from the health cluster indicated that 3.3% of the HRP has already been funded, only 3.3%. Out of, for the COVID-19, no more than 20% for the preparedness of the COVID-19, which is really important. As for the COVID-19 response, we urgently want to fund and support the preventive measures, provide adequate support to the Syrian partners, notably for isolation centers, medical equipment, and PPE. Definitely the most important thing is also rebuilding and the long-term building of health infrastructure, especially the medical education that has been highlighted by all our colleagues here in this call, improving the health infrastructure and supporting the health governance. All of these things are really important in these times, and the COVID-19 has showed that for us. And for any more details, please, we have our colleagues that are online, and you can reach to all of our colleagues that are working in the health cluster and the Syrian NGO. Dr. Bachir, Dr. Okba, Amani, and Dr. Mohammad, thank you so much for this, and thank you all for attending. We'll end now this